So maybe let's begin. So again, be most welcomed. I'm the chairman of this session. It's an honor, and it's maybe the first time here in EACD. I'm Dr. Guy Letellier, and I'm a pediatrician and a PM&R specialist in northwestern part of France. And here with two of my colleagues, and you will see that the unexpected guest I was telling you about is actually COVID, and it hit our Dr. Annela Sugar, which is still in UK, but she will meet us with a Zoom connection. To make the intro about nutritional issues and needs in children with neurodisabilities, of course, my link of interest today is with Nestle Health Science, which I'm really pleased to thank today, because they managed to have this topic really livable with our children. The children, you know who they are, because with generalized severe impairments, and they can experience very great swallowing deficits. You can see them among many causes of dysphagia, with the TBI, neurological disorders of any kind, cerebral palsy. We will have some focus about it, with the issue of prematurity, but as well with any kind of issues with tracheotomy, ventilator dependencies, some craniofacial abnormalities, and generally speaking, failure to thrive. And Lefton Grief, the mother of all these studies, made that reflection some time ago already. In 2016, we could figure out that, of course, it was an evidence, but we had to prove it, that the lower GMFCS you have, the better chances you have to grow taller and to be fit in your body. And the lower GMFCS level you have, I mean, GMFCS 4 to 5, and you get skinnier, you get smaller, and it has to do with how you get fed, okay? Either with the nutritional issues or with the swallowing issues. One woman I admire a lot is Joanna Arvidsson from the US, who already posted that on her paper in 2013 about the red flags. These questions you ask quite easily during your clinics, with the 4 questions that tells you how there's failure to thrive, to get well nourished, and having eventually swallowing difficulties. With how long does it take your child to be fed? Or is it somehow stressful for you, for your child? Other question is it gaining weight adequately? And are there any signs of respiratory problems? Okay, and whether you answer these questions, you can raise a red flag and be aware of that condition that affects our, generally speaking, our children with neurodisabilities, and CP children, for instance. And Belle and her Australian colleagues could develop that idea until they found that feeding and swallowing nutritional score, FNST, that led you through some other questions that were, the paper is well written, it was in 2019, and it gives you some path to follow if there's really an issue with nutrition and swallowing problems, okay? We talked this morning about other kinds of measures, about fidgeting for the children. Here we are trying to know how swallowing could be a risk or a chance to be severely impacted. As I told you, other scores were risen, in some papers, and from 2014, the initial paper about the PD-EAT. And do not misunderstand PD-EAT here and PD-EAT tool that Dr. Arslan will tell us about in a few minutes. Again, you don't have to be really invasive. For instance, you have to pick up the right answers to the questions you can ask to the mothers and to the carers. Have here and maybe likely to be read. Is it drooling? There are some posters very well written here at the EACD about drooling issues, and how the child is being fed. Okay, this generally speaking, how you can manage to understand that it is something that affects most of our children. The parents themselves could, through this paper, explained that about 40% of the preschool children had, reported some issues with fluid and food texture modifications in order to be fed. The children consumed more or less high energy or lower energy because of their gross motor function issue, and 50% had commonly unsafe swallowing issues. Okay, so we have the carers, mothers, parents, and the families themselves that gather in these different papers, and of course excellent reviews, DMCN, if you don't know it yet. What issues? There was a meeting last week in Austria about our GE specialists, and they again enhanced nutritional issues and this malaise of malnutrition that has to be told to specialists like we who are dealing with these people in order to have better strength in our muscles, in the muscle of these children, and this psychomotor development. If you're in a wheelchair, if you have a lack of mobility, it needs, of course, to rehearse the basic metabolism, maybe up to 120%, or most probably lower it to 60 or 70%, which needs sometimes special formulas that you can catch up in different good booths. According to what you can evaluate, like muscle activity, hyper or hypotonia, any dystonia, any abnormal movement will help you to answer to that question. What does he need really to be fed? More protein, less protein, or less calories? These intakes have to catch up steatopondyral growth, or maybe just to follow his own path, not just trying to catch up a curve that has something to do with typical development children, and instead of children that here have some motor impairment. So a long time ago, that GMCS1 would probably need less nutritional support than the one who is more impacted in their body, in their motor scale. So it's quite linear, actually, if you look at this picture. What I tried to be somehow original with some unpublished data. For instance, 200 patients underwent video fluoroscopy swallowing study, and with quite young people, and mid-age was 3.6 years, and we saw that most of them were referred for respiratory problems, some feeding problems, weight retardations, okay, more or less 40%, and 32% of them had a real aspiration during that test, okay? Eventually you can figure it out clinically, but now you have the test, and now you can prove, and you can try to enhance that issue with trying different textures, the tempo you give the food, you give the fluid intake. So that's the right measurement. I won't make a talk only about VFSS, but just to tell you that 50% of these children had neurological disorders, and 100% of them had swallowing issues. So the take-home message is, please do assess dysphagia in these children with neurodisabilities. I was talking about that great conference, ESPGHAN, that tells us again, early detection. That's the main word here in the EACD. We started quite strongly this morning with some talks about the early detection of movements, but here we are talking about swallowing issues. You got to position them, physiotherapists here in the room, occupational therapists, and of course PMNR specialists are in a gripping condition, to try to position correctly the child, whatever age he has, and to find out what nutritional support he could need, either nothing or enrichment until nasogastric tube feeding, for example. The EBSCAN told us again how to follow up these children with any kind of anthropometry, what kind of micronutrients could be needed and not being, put away. And of course, the basic thing is to wait and to measure the children. If you click that link to the ESPGHAN down below, where's my pointer? You can download the latest recommendations. I think it's 2019 and it's still okay. So how to evaluate and mitigate these issues? So I'm really, really pleased to welcome Dr. Selene Aslan.
Thank you, Dr. Guy, for the nice presentation. First of all, I would like to thank you for coming and joining us today's session. And also thanks to organizing committee and Nestle Health Science for their awareness and organizing this session. And I would like to introduce you myself first. I am Selene. I work on Hacettepe University Faculty of Physical Therapy and Rehabilitation and work for about 13 years about dysphagia. And my topic is importance of early detection of swallowing problems, introduction to new PEDI-10 tool. Briefly, swallowing system, as you can see here, consists of oral cavity, upper and lower esophageal sphincter, pharynx, and the body of the esophagus. And this system, as you can see in the figure, works as a pressure system to transport the foods and drinks from mouth to the stomach and prevent its reflux into the esophagus. Any difficulties in any phases of this swallowing refers to swallowing disorders, or we can also name it as dysphagia, or more recent and comprehensive term, deglutition disorders. And we can see dysphagia from infancy to elderly. And when we see it in children, we call it as pediatric dysphagia. And its prevalence is really increasing due to the improved survival rates of children with prematurity, low birth weight, and complex medical conditions. And when we look at children with neurological impairments, we also commonly see in dysphagia in excess of 90%. And you can see here, sometimes it's exceeded up to 99% with different severity levels. And it's really important because its complications, we can see here, it's undernutrition, dehydration, recurrent pneumonia, weakened immune system, prolonged and frequent hospitalizations, increased risk of morbidity and mortality of children, and eventually decreased, it's an important point, quality of life of both children and their parents. And therefore, due to all these complications, it's important to define, as Dr. Guy said, dysphagia and plan appropriate management plan as an early period. And besides our clinical experience, ESPEGAN working group also suggests that we should plan dysphagia management as a clinical decision-making process. And it's a step-by-step approach which starts with evaluation of swallowing system. It's the important and first step to detect dysphagia and proceed the next steps. It's our first steps. And you can see the evaluation algorithm of our center, which is Hacettepe University Swallowing Disorders Application and Research Center. Pediatric patients who refer with coughing, choking during swallowing, wheezing, any stuck sensation in throat or chest, vomiting, wet vocal quality after swallowing, inability to gain weight, or recurrent pneumonia history, we think that these patients are at risk of some swallowing problems and refer to a swallowing evaluation process. And as you can see here, we have screening tools in the first step, and screening tools are used to indicate the need for further swallowing evaluation, as video fluoroscopic swallowing evaluation or fiber optic swallowing evaluations. And this screening process is really important for this step-by-step evaluation algorithm. During the time we developed PEDI-10 tool, there was a gap there for pediatric swallowing evaluation, especially to detect children at high risk of penetration and aspiration. This is the main rationale of the idea of creating the PEDI-10 tool. When we look at the literature, there are several non-instrumental evaluations, as Dr. Guy also mentioned about some of them. But we want to develop a scale that can detect children at high risk of penetration, airway penetration and aspiration. As an example, the 10-item EAT-10 assessment tool, which is developed for adult patients, is a frequently used screening tool in clinical settings in dysphagia management. And when you look at the citation scores of the EAT-10 tool, it's also frequently used in research. Therefore, we think that having a parent-reported tool that has similar ability to detect penetration aspiration risk in children will help identify patients at risk for dysphagia complications. Therefore, we performed this study in cooperation with Hacettepe University and University of California, Davis. We had two separate developmental phases. In the first phase, we have item generation, content validity, and normative data generation phases. For item generation, we used the validated items from the EAT-10 tool, but during the adapting items of the EAT-10 to PED-EAT-10, we used comprehensive pediatric dysphagia literature and expert opinions to consider that if these items were appropriate for the pediatric population. Therefore, during the content validity, we included 7 professionals with expertise in pediatric swallowing disorders with 2 Delphi rounds, and for 7 experts, the content validity index was supposed to be minimum of 0.8 degrees. And for normative data generation, we included 51 healthy children and used the same calculation as the EAT-10 developmental study. For reliability and validity part, we included 138 children with spastic cerebral palsy children, and we evaluated swallowing function of these children with videofluoroscopic swallowing evaluation, which is a gold standard of swallowing evaluation, and used the penetration aspiration scores to assess penetration and aspiration severity. And then we also ask parents to complete PED-10 on 2 separate occasions for test reliability issues. We assessed internal consistency with Cronbach alpha and look at correlation between PED-10 and PAS scores for criterion-based validity of the PED-10. In terms of results, we adapted PED-10 from EAT-10, retaining the same structure as the original scale. As you can see, it's really simple 10 questions, and it should be, you can ask parents to score each item from 0 to 4, which shows increasing levels of severity. After Delphi rounds, during that rounds, we changed one of the item as my child gags during swallowing instead of one question in EAT-10 scale. As a result, after Delphi rounds, according to experts' ratings, the content validity index was determined to be 0.91 as sufficient, and the normative data suggests that a PED-10 score of 4 or higher means abnormal swallowing. In terms of the second phase, internal consistency was found to be high with 0.87 Cronbach alpha values, and you can see the initial and retest scores of the PED-10 and ICC scores of the each item range between 0.93 to 98. Which shows us that this tool is a consistent scale for determining the risk of penetration aspiration scores in children. And PED-10 and PAS scores were excellently correlated, which shows us that this tool has sufficient criterion validity. After we developed PED-10, its scores ranged between 0 to 40, and a PED-10 score of 4 or higher was reported as abnormal. But abnormal swallowing refers a wide range, and our aim is to evaluate the ability of this tool to predict aspiration in children with neurological impairments. So we performed the second study with these children, and you can see the distribution of our patients. and found that according to Rock curve, a cut value of 13 from the PDE-10 correctly identified 77% of children with airway aspiration, and these children were 2 times more likely to aspirate. Therefore, according to these 2 studies, a PDE-10 score of 4 or higher shows abnormal swallowing, which is the child may have a swallowing problem, and patients with a score of 13 means that these children are at risk of airway aspiration, such as the child likely have a swallowing problem, especially for airway aspiration. And to date, the PDE-10 is translated into two different languages, Arabic and Spanish versions, and they also investigated these validity and reliability issues, and there are also some ongoing translation studies. And at the end, you can all see, I would like to introduce you the digital version of the PDE-10 according to our collaboration with Nestle Health Science. The digital version allows us to rapidly get the results and its interpretation, and you can see, you can scan here and reach the instrument here. And I would like to thank to Nestle Health Science again for their awareness and their efforts to spread the use of PDE-10 tool. And thank you for you to come and join and listening to our session. Thank you.
Just declaring my conflict of interest, the study was funded by Nestle Healthcare. So the management of pediatric dysphagia typically starts with the assessment of the infant or the child's eating and drinking. And this entails evaluation of various oral and general motor skills and mealtime observations, taking a very thorough case history and obtaining information from other professionals in the multidisciplinary team. So research has alluded to some shortfalls in the practice where institutions develop their own informal proformas and not using standardized assessment tools. And previous systematic reviews of assessment tools have criticized these tools in terms of lack of psychometric properties. But there has been a move and some progress in this, as we've just heard from Selene, with a recently validated PDE-10 that has been published, and this will have a significant impact on the improvement of the assessment, especially because it entails such a strong parental report component, which can identify dysphagia, and not only identify the dysphagia, but also to be used as an outcome measure tool for regarding the treatment. So the clinical feeding assessment can be supplemented with the use of instrumental assessment, especially to rule out silent aspiration, meaning that the aspiration doesn't trigger a cough response, because this is actually quite highly prevalent in the pediatric population, especially in otherwise healthy and typically developing children with unexplained respiratory symptoms. So to summarize, is that evidence-based practice in assessment is vital as it directs our treatment. So looking at the management strategies that we have in dysphagia, these can be direct and indirect, and we often use a combination of both. And today we will focus specifically on texture modification. So the International Dysphagia Diet Standardization Initiative, which with the acronym EACD framework, sets out very clear and specific terminology and descriptors to describe various consistency levels, with level 1 to 4, which you can see here, describing fluids, and then levels 3 and 4, there's a bit of an overlap, up to level 7 for solid foods. And this allows for consistency in practice and communication between healthcare professionals, and also between us as healthcare professionals and parents and patients, which ultimately improves safety of practice. It also supports research. So the use of thickness to increase fluid consistency is a well-known and standard practice in pediatric dysphagia. It supports bolus transfer during the oral and pharyngeal stages of the swallow, and published literature in pediatric dysphagia has demonstrated the effectiveness of thickened liquids in the reduction of respiratory symptoms and also liquid intake, but very importantly, parental satisfaction in using the thickeners. As in the practice of adult dysphagia, there has been some criticism against the use of thickeners, proposing the use of a free sterile water protocol as opposed to the thickened liquids itself. However, at present, there's no evidence to support this practice to be safe in pediatrics, especially if we consider that these children still have developing lungs. So there's currently a very limited range of thickeners on the market available for use for children under the age of 3 years. So what we did is we investigated the effectiveness and the tolerance of Resource Thicken Up Junior, which is suitable for children 6 months and older with a diagnosis of gastroesophageal reflux disease and dysphagia. So this product contains a 10:1 ratio of locust bean gum and xanthan gum. And we used a prospective study, which was approved by our local ethics committees, which we conducted during the period of 2021 to 2022. We had a bit of COVID interfering with the progress. So for the study, we had very, very specific inclusion and exclusion criteria. Very important that we did ask parents not to introduce any new foods during this trial so that we could control variables which could potentially have an impact on the tolerance. And then from an exclusion point of view, excuse me, we excluded any subjects with a potential cow's milk protein allergy because the product is made in a factory where and there's some exposure to other milk-based products. So we recruited 15 patients who actively participated in the trial. We did, of course, approached a lot more. And these children had to be actively managed by a speech language therapist and a multidisciplinary team for dysphagia. And we asked the parents to complete a 30-day diary, both of the intake, so the volume of thickened liquids, but also the tolerance. So in terms of tolerance, very specific gastrointestinal symptoms, and also monitoring stools, for which we use the Bristol stool chart. So in terms of our recruits, we had 15, like I said, and we covered quite a wide age range. And the subjects had a range of diagnosis. And I want to allude specifically again to this otherwise healthy and typically developing children with recurrent respiratory infections, which is a group of children we see a lot more of now in clinic, likely because there's better awareness, but also better diagnostics. So we provided the parents with education regarding the use of Resource Thicken Up Junior, specific to the required level of fluid consistency, identified as safe for that specific subject based on the video fluoroscopy swallow study findings. And we directed the parents to the product's website, which provides very comprehensive and detailed instructions on the method of thickening based on the identified ITSI levels. And this is really important. The education around managing thickened liquids has a significant effect on compliance. Okay. So also because it gives you information on how to thicken very specific products. So in terms of our study outcome, very positive, increased hydration through improved intake of thickened liquids, and some GI symptoms reported, which was more transient in nature. We also had some really good feedback, although this was not part of the study, on the impact that it had on the patient and the parent, specifically nursery schools that felt more confident. But also the potential impact that this has on our healthcare system through, firstly, enhanced patient experience, secondly, safer practice, because we know what we prescribed is what the parents would be able to achieve at home, but the cost implications, considering that this patient who kindly gave me permission to share these photos, entire treatment cost the national health system just under £30,000. So I'd like to end by thanking all our families who participated, trusting us to trial this product and supporting them in their journey. Thank you very much.